Okay, with impingement, that can mimic carpal tunnel. So impingement is basically infringement or an impingement of a nerve. So in this case, we've been looking at median nerve, and the median nerve, which starts in the neck, comes down the arm. Anywhere in this kinetic chain can get impinged. So there's different tests, different orthopedic tests that you can do to differentiate between actual carpal tunnel and perhaps impingement that is mimicking carpal tunnel. So by doing these methods, you can be avoiding surgery, and these people get remarkable improvement through conservative management, your therapies, ergonomic training, and so on. Okay, continue with the appendicular skeleton. Here's the entire lumbopelvic girdle or sacropelvic. So we have sacrum here, and then the os coxa, which is the entire hip bone, right and left. And the os coxa is made of 3 bones: the ilium, the ischium, and the pubis. Over here we're seeing a male pelvis with a more narrow inlet and pelvic rim or brim, and a pubic arch less than 90 degrees, and a female pelvis which has a wider pelvic brim and a pubic arch that is greater than 90 degrees. This diagram is showing you simply that the pelvis and the lumbosacral spine is always under a mechanical load because of our body weight, because of gravity. So it is easily misaligned as force is distributed through the lumbar spine and the SI joints, and as force is coming up through the femur and into the pubis and pubic symphysis. This can create some problems. If there's a misalignment, if there's a sublux, and so forth, it's very hard for the body to auto-correct because it's such a big weight-bearing area. So this is where help comes in with your adjustments and your therapies and so forth to get the lumbopelvic pain corrected. Okay, this is your femur, your thigh bone, and here is the tib fib. So the tibia is the bigger bone, the fibula is the smaller bone. Now, as far as all the details, go back to the bone lectures and the lab test review to go over the specific parts of bone. You will see those again on the lecture test. It'll be in written form rather than gross anatomy. So I do encourage you to go back and look through all of those lab skeleton bone reviews, because on the test, on the lecture test, you're going to see them again just through written form. Okay, the foot, we have the tarsals, metatarsals, and phalanges. Okay, keep in mind that the way we name the tarsals is the same way as the hand, where this is metatarsal number 1, metatarsal 2, all the way to metatarsal 5. Phalanx 1, so proximal phalanx 1, proximal phalanx number 5. Okay, this diagram is showing you foot mechanics. So very quickly, what I want you to know is that when you're in the mid-stance state like this, your foot has a certain distance from the heel to the metatarsal phalangeal joint. When you bend, there's a change in angle at the metatarsal phalangeal joint, and the heel approximates closer to the metatarsal phalangeal joint there. So this is an important concept to understand because this is where plantar fasciitis and other foot problems come from. So all this that you're seeing here, if a person's foot mechanics is messed up, it's going to lead to problems. So here's another picture of that. So mid-stance. Okay, this is propulsion gate. Look at the change in angle. Okay, now this is normal with walking or running. So this is not by any means an abnormal diagram. This is just showing you what goes on biomechanically. So at the calcaneus, we have In the mid stance, you have pronation of the calcaneus, internal rotation of the talus, pronation of the navicular, and supination of the cuneiform. When you do the propulsion gate, there's a change in angle here at the metatarsal phalangeal joint, and then all those bones go the other way. So now we have supination at the calcaneus, external rotation at the talus, supination at the navicular, and pronation at the cuneiforms. Okay, so when I do a foot assessment, this is the stuff that I'm looking for, and you can tell when all this is not working right. You know, it may be one part or several parts, but nevertheless, you're going to find something that mechanically is not working right, and their foundation, which is their foot, is now altered, which creates problems. Such as Morton's neuroma, metatarsal fractures. I do want you to know these. Okay, so pause this when you need to, write them down, make your note cards. A Morton's neuroma is impingement of the plantar nerves, and that hurts. And that happens from abnormal biomechanics. You can get a March fracture, also known as a metatarsal fracture or a stress fracture. Okay, the bones can break, not because you jumped out of a 3-story window, because you're just walking with excessive abnormal wear and tear, and the bones start to break. Then you can get bunions, usually from excessive pronation over your lifetime, corns, calluses, plantar fasciitis, and heel spurs. So these are some of the foot problems that develop because of altered gait. Your foundation, which is your feet, which can mess up knee, can mess with your hip and low back. That whole kinetic chain can get messed up because of your foundation. So that's why, as a sports medicine practitioner, I think it's very important that you look at people's feet. Let's go to this page. Look at how they're standing. So if you get down, look at the ground level. Are they supinating? Do they have a neutral position, which is ideal and what you want? Or are they pronating? Pronating is the more common. So when they pronate, you can get medial meniscal tears and altered, just a bunch of problems that can happen up and down the kinetic chain here. So this diagram is showing you the functional hallucis limitus test. Now keep in mind your big toe is also called the hallux. So the test is you take the great toe, the hallux, you lift it up, and you should get a certain type of movement that you're looking for. And once you detect that the tib fib is not moving properly, the metatarsal phalangeal joint's not moving properly, we have a problem. So we go in and correct that. Realign the bones, do your tissue work, some re-education and so forth to get it better. Oftentimes you're going to have to fit them with an orthotic to correct the pronation, get the foot back in the neutral position. Once you do this, that pain that they were having, that they're constantly taking painkillers for, which wasn't fixing the underlying problem, all that pain goes away. They have improved function. You increase function, you're going to decrease pain. Okay? If you continue to live in dysfunction, pronating, abnormal knee and hip mechanics and all that, that's creating all this pain and inflammation that will lead to degeneration and arthritis. Painkillers, it doesn't fix that. Adjustments, rehab, soft tissue work, orthotics, and so forth, that's what fixes it. Okay, this is an x-ray of a hand. So on the left picture here, that's the beginning phases of rheumatoid arthritis. You can see the bone is very white and still has its minerals, but over here, as you can see, it's demineralizing. The bone is very gray now, losing bone mass. If you look at the joints, you can see a joint space on the left side, but on the right side, obliteration of the joint space, letting you see advanced inflammatory arthritis. Kill in the joints. This hurts. You can also see the deviation, the ulnar deviation in the hand. So these are classic presentations of what rheumatoid arthritis of the hand looks like on X-ray.